So welcome to the Triage Cancer webinar series. Today's topic is Medicare, What's New in 2025. This webinar is presented by our senior staff attorney, Amanda Goodstadt. Prior to joining our organization, she spent more than a decade counseling seniors and caregivers about Medicare and related benefits, and was also a certified New York State Health Insurance Assistance Program counselor. Amanda, I'll let you take it away.
Thanks so much, Shelby, and thanks to everybody joining us today. I know that all of you on the call may have different levels of knowledge and experience with Medicare. So I'm going to start out just with a very quick reminder that when we are talking about Medicare, we are talking about public health insurance for U.S. citizens and for certain legal residents if they fall into one of three categories. Medicare is for people who are age 65 and older, or people who are under 65 but have been receiving Social Security disability benefits for at least 2 years, or people who have end-stage renal disease or ALS. Our most recent data tells us approximately 1 in 5 Americans has Medicare. That's nearly 68 million people. If you changed something about your Medicare coverage during last fall's open enrollment period, those changes became effective as of January 1st. We're only a couple of days away from February at this point, so hopefully anyone who made a change has all of their new plan materials, including any new insurance cards. But if you don't, or if you're working with a patient who doesn't, you or the patient can call the plan, ask for those materials. You also might be able to log into an online account and print a copy of any new insurance card. If you have to go to the doctor or you need to fill a prescription and you don't have the new card or cards that you need, you can still go. When you go, bring your red, white, and blue Medicare card, the one that you saw on the previous slide. Bring photo ID. Bring whatever letter you have or printout you have that confirms that you enrolled in the new plan. And if you get any financial assistance paying for your Medicare, bring proof of that. That means bring your Medicaid card if you have one, or bring a letter that confirms your eligibility for extra help. Remember, if you absolutely have to, you can go to the doctor, get the service you need, fill the prescription, pay out of pocket, and seek reimbursement from the plan after the fact. Medicare is a pretty complicated program, and it is the source of a lot of questions that we at Triage Cancer get from consumers and from healthcare professionals. In September, we presented a webinar called Medicare 101, where we walked people through the basics of Medicare. We talked about the structure of Medicare. We talked about supplemental coverage, or the Medigaps. We talked about the Medicare Advantage program. We talked about enrollment periods and appeals and financial assistance. And we walked people through a variety of exercises to show them how to compare Medicare plan options. If you have questions about any of those basics, any of those topics, or you want to see the exercises, we suggest watching the recording of that video that is up on our website. Today, we are going to cover some information that you may have heard if you were attending Medicare 101, but that's only because it's difficult to talk about some of the things that are changing without providing some basics. But our focus today is really on things that are new in 2025 and things that people should be thinking about at the start of a new plan year. And the way I'm going to do that is by sharing 10 questions that our office has been getting, and then sharing the answers to those questions with you. So jumping in, the first question that I know is always on people's minds is about what Medicare is going to cost this year. Medicare announces new cost numbers throughout the year, but a lot of the cost-related information for 2025 wasn't released until late last year. Now, before I get into the specific costs, I want to make sure that we're all on the same page about what the different cost-related terms that I'm going to use mean. First, there is the cost just to have Medicare, the cost to have the health insurance to begin with, and that's your premium. A fixed dollar amount you're paying each month. You're paying that same premium whether you spend the year never going to the doctor and never taking a prescription medication, or whether you are spending the year with a serious health situation that means you are going to multiple doctors multiple times a week. Then there's the cost when you actually are using your Medicare, when you're using that health insurance. There's a few terms associated with that. The first one is deductible. Your deductible is a fixed dollar amount that you are paying out of pocket before your insurance starts to contribute towards the cost of your medical expenses. Deductibles can be very low, they can be very high. There are even plans that have no deductible, or what's called a $0 deductible. If you have a $0 deductible plan, that means your plan is starting to contribute to your costs from the very first moment that you are getting healthcare. There's a cost, of course, each time you go and get healthcare, each time you go to the doctor, or you pay for a test, or you have to fill a prescription. That sort of cost is expressed in one of two ways, either as a fixed dollar amount, in which case it's called a copayment, or as a percentage of total cost, in which case we call it a coinsurance or a cost share. The final cost-related term I'm going to use today is out-of-pocket maximum, and you're going to hear that term a lot. I find that many people confuse deductibles with out-of-pocket maximums. Once someone reaches their plan's out-of-pocket maximum, their plan takes over and pays 100% of covered costs for the remainder of the plan year. To figure out which things that you're paying for are going to count towards getting to your out-of-pocket maximum, you have to read the terms of your plan. And also, when it comes to Medicare, I'm going to tell you throughout today's presentation, when you're hearing that term, what it includes. Okay, so let's jump into these actual costs for 2025. First, we have Medicare Part A. Part A is hospital insurance. This is the part of Medicare that pays for things like an inpatient stay at a hospital, a stay at a skilled nursing facility. It pays for very limited nursing home care, for certain home health care, and it's also the part of Medicare that pays for hospice. Generally speaking, if someone has worked and paid into Social Security, Part A is premium free. There's no monthly cost just to have the coverage. If you haven't paid into Social Security, or you haven't paid in for long enough, you can still get Part A, but you're going to pay a monthly premium for it. And this year, you're either going to pay $285 a month or $518 a month, depending on how many work credits you or your spouse had from Social Security. 99% of people with Medicare or Medicare beneficiaries don't have a Part A premium. Now, even if you're one of the 99% that doesn't have a premium, you still have other costs that are associated with Part A. You have a deductible. It's $1,676 per benefit period. The Medicare Part A deductible is a little different from most other health insurance deductibles. Most of those deductibles are per year, but Part A's is per benefit period. A benefit period starts the first day someone is admitted to a hospital or skilled nursing facility, and it ends when that person hasn't gotten any inpatient care for 60 days in a row. What this allows for is that if you're in the hospital next week for a few days and then you're discharged, but then you wind up back in the hospital 2 weeks later, you don't have your deductible resetting every time you set foot in that hospital. Having said that, though, depending on someone's health situation, it is still possible that they could have more than one benefit period take place within a calendar year and have to pay that deductible more than once within a calendar year. Part A also has copayments. The amount is based on what day number it is that someone is either in a hospital or in a skilled nursing facility. So the amounts on the slide show you copayment amounts for inpatient hospital stays. Medicare Part B is medical insurance. This is the part of Medicare that is paying for things like a visit to a doctor, paying for all your outpatient care, lab tests, imaging tests, preventive care, durable medical equipment. All of this is covered under Medicare Part B. Medicare Part B has a monthly premium, even if you're one of those people who doesn't have to pay a premium for Part A. And this year, the standard monthly premium is $185. That's what most people are paying. But if Medicare considers someone to have a high income, they're going to pay more. And exactly how much more depends on exactly how high the income is. But to give you a sense, for this year, a single person would be considered to have a high income if they have $106,000 or more income. It would be $212,000 or more. Part B has an annual deductible. This year it's $257. And the program is a cost share. Medicare pays 80% of costs. The Medicare beneficiary pays the remaining 20% out of their own pocket. There's no out-of-pocket maximum. Unlike with the marketplace or with most employer-sponsored plans, there's no cap. So if you are someone with a serious health condition like cancer, costs can really add up. And that's one of the reasons why people will purchase Medigap plans or have supplemental coverage to help them with some of the out-of-pocket costs. Medicare Parts A and B together are what we call original Medicare. That is all of Medicare that existed when it was first signed into law. And original Medicare is a fee-for-service program. In the United States, we have two healthcare payment systems, the first of which is fee-for-service. That is a plan where services are each paid separately. A fee-for-service plan gives a consumer the greatest choice of healthcare providers. So if you have original Medicare, you can see any provider, you can go to any doctor, you can be treated at any hospital anywhere in the US as long as the provider accepts Medicare. The other healthcare payment system that we have in this country is managed care. That's the system where an insurance plan goes out and contracts with different providers, with different networks of or groups of doctors or hospitals or labs. And the insurance plan and those providers pre-agree to what different types of care are going to cost for people in the plan. Medicare Advantage plans are managed care plans. That brings us to Medicare Part C because that is the part of Medicare that created the Medicare Advantage program. To enroll in a Medicare Advantage plan, you first have to be enrolled in both Medicare Parts A and B. And if you are, you have the option of purchasing one of these managed care plans that are sold by private insurance companies. These plans bundle together all the services that someone would otherwise get under Parts A and B. And then the vast majority of these plans also include prescription drug benefits, which are from Medicare Part D. The plans can be structured in a few different ways, and each plan has its own network of providers. Let's talk about this year's costs in Medicare Advantage. So first of all, each Medicare Advantage plan gets to decide if it's going to have a premium. The premiums can vary. Some of them don't have any premium. But what's really important to understand is that any premium in a Medicare Advantage plan is on top of paying your Part B premium, not instead of it. Each of the Advantage plans will have its own deductible and co-payments and co-insurance structure. But the other way in which Medicare Advantage plans are very different from original Medicare is that by law, these plans have to have out-of-pocket maximums. This year, the highest out-of-pocket maximum that one of these plans can set is $9,350 for in-network services. An out-of-pocket maximum in a Medicare Advantage plan is just for what a consumer is going to have to pay for hospital and medical services. In other words, The out-of-pocket maximum is just looking at amounts someone is paying for services that otherwise would have been covered under Medicare Parts A or B. It has nothing to do with prescription drug costs. We're going to talk about that separately. There are a lot of Medicare Advantage plans out there. This year, there are just over 3,700 of them. Most of them are structured as either HMOs or PPOs. And the average person who has Medicare is choosing among 42 plans. In some parts of the country, they have many more choices, and some they'll have less. But on average, it's 42, 34 of which would also include drug coverage. One of the big selling points for Medicare Advantage plans is they can offer benefits beyond what original Medicare offers. So a lot of these plans will include coverage for things like routine dental care or routine vision care or hearing aids. Some of them will include things like transportation to and from certain medical appointments or meals when someone gets discharged from the hospital, all things that original Medicare would not include. Even though there are so many choices, it's only a small group of insurers who sort of dominate the market. And between United Healthcare and Humana, that's almost half of the plans right there. As of this year, the enrollment in original Medicare versus Medicare Advantage is pretty even. There are slightly more people who are enrolled in Medicare Advantage plans, but Medicare Advantage enrollment is growing, and it's only projected to keep growing. Oops. Sorry. So we just went through 2025 costs for Medicare Part A, hospital insurance, Part B, medical insurance, and Part C, the Medicare Advantage program. What about the cost for Medicare Part D? And what else is changing with Part D this year? And that is a very hot topic of conversation because there are some significant changes to Part D for 2025. Part D is Medicare's prescription drug benefit, and it is made up entirely of plans sold by private insurance companies. There's no original Part D. There's no government Part D. The plans have different costs associated with them. So first of all, the plans can decide on a premium, and it's going to vary. There are plans out there, you see the range for this year on the slide. There are some that are super inexpensive. There are some that are super expensive. On top of that, if you are considered high income, the way we were talking about with Part B, you're going to have an additional amount tacked on to the list price of the plan you're looking at. The plans also decide whether they want to have a deductible. If they decide they want a deductible this year, the highest deductible one of these plans can set is $590. And then the plans are going to vary in terms of copayments and coinsurance amounts and in terms of what drugs they cover. And so it is possible that two people could have the very same Medicare Part D plan, but end up paying very different amounts for it because they are taking completely different prescription medications. Before I keep talking about Part D and changes for this year, I have to share a little bit of history because I know a lot of the people who are listening may have had Medicare for a long time at this point, or may have worked in the Medicare world for a long time at this point. And the longer you've been around Medicare, the more changes you are seeing with it. Between 1965, when Medicare becomes law for the first time, and 2006, Medicare doesn't have any coverage for prescription drugs, which when you think about it, or when I think about it, I find pretty amazing. This is a health insurance program for the elderly and for people with disabilities, two populations that are highly likely to need prescription medication, yet the insurance program didn't provide any coverage for the first 40 plus years that it was around. In 2003, a new law is passed that creates Part D, and Part D becomes effective at the beginning of 2006, which is really good news. But it's not a perfect program, still isn't a perfect program. And there were a bunch of challenges with it. And one of the biggest issues with it when it's initially starting is that if someone has really high prescription drug costs, they could fall into what was called the coverage gap or the donut hole. There was this period of time during the year when someone had a literal gap in their drug coverage and had to pay for 100% of the costs of their drugs, even though they had insurance and even though the drugs were covered by that insurance. This is a really big problem. And when the Affordable Care Act comes along in 2010, it is one of the issues with Medicare that it addressed. The Affordable Care Act worked to close the donut hole for consumers a little bit at a time over a 10-year period, so that by 2020, there is no longer a period of time where someone who has a Part D plan has to pay 100% of the cost of the drugs covered by that plan. This is really good progress, but it still doesn't solve all the problems people are having with high drug costs. And once the donut hole is resolved to a great degree, one of the big concerns that people turn to is the fact that there's no out-of-pocket maximum for drug costs. So that people, for example, someone with a cancer diagnosis taking a lot of specialty medications could be looking still at thousands of dollars of bills for those medications. In 2022, the Inflation Reduction Act is passed, and that law tries to address this issue, tries to address the fact that there's no out-of-pocket maximum for drug costs, and it comes up with a solution, but the solution takes a few years to fully implement. Last year is the first year of the implementation, and so I want to just take you back in time a little bit and show you how the drug benefit worked last year. The first thing someone with a Medicare drug plan was paying was their deductible if their plan had one. And last year, that was anything between $0 and $545. And once they satisfied their deductible, they moved into what is called initial coverage. And during this period of time, the Medicare beneficiary pays 25% of the cost of covered drugs. And the balance is paid in combination by their drug plan and by really, really steep discounts that drug companies are required to give on brand name drugs. Someone stays in initial coverage. They could stay in initial coverage the whole year, but if their total out-of-pocket drug costs reach $8,000, they move from initial coverage to catastrophic coverage. Before 2024, if someone moved into catastrophic coverage, they had to pay less for their covered drugs, but they still had to pay something. In 2024, that goes away, and the beneficiary no longer has to pay anything once they reach catastrophic coverage. The $8,000 amount excuse me, is a little bit misleading because when you look and count up money to see when you get to the 8,000, you don't just count what the beneficiary was pulling out of their pocket or pulling out of their checking account. You also get to count the value of those really steep discounts that I mentioned the drug companies giving. And so the reality was someone last year used to hit catastrophic coverage once they paid around $3,300 out of their own pocket for covered drugs. So this is the first time we have an out-of-pocket maximum for drug costs. This year, it looks a little different. In some ways, it looks similar, but in some ways different. So again, the first thing someone's going to pay this year if they have drug coverage is their deductible, anything between $0 and $590. They then move into initial coverage, and the beneficiary, pardon me, is still paying 25% of the cost of covered drugs. That continues unless and until the beneficiary has paid $2,000 out of their own pocket on covered drug costs. At that point, that person moves into catastrophic coverage and no longer has to pay anything for covered drugs. So we have a true $2,000 out-of-pocket maximum on Medicare drug costs. This applies whether someone is in original Medicare and has a standalone Part D drug plan. And it also applies if you have a Medicare Advantage plan that includes drug coverage, which again is most of those plans. This doesn't apply to things like over-the-counter drugs or drugs that aren't covered by your Part D plan. It doesn't apply if a drug isn't covered by Part D, but is covered by another part of Medicare. So for example, if you're in the hospital as an inpatient and you're getting prescription drugs dispensed from your nurse, that's covered under Medicare Part A. Or if you're getting IV chemotherapy administered at a doctor's office, that's covered under Medicare Part B. Those costs are paid by a different part of Medicare, and they are not going towards satisfying this $2,000 out-of-pocket maximum. If your drug plan has a deductible, anything you're paying towards that deductible will count towards getting you to the $2,000. And also just keep in mind that the $2,000 won't stay $2,000 past this year. It's going to increase with inflation. And for 2026, they've already proposed it's going to be $2,100. How big a deal is this? The government has done studies to try and figure out what kind of money are people saving as a result of out-of-pocket maximum. And one this out of the Department of Health and Human Services published a research series studying this question. And they had some interesting things to say. So last fall, they published this information saying last year, when we basically had our $3,300 out-of-pocket maximum, about 1.5 million people in the Medicare program hit that out-of-pocket maximum midway through the year. So by June 30th, 1.5 million people had reached catastrophic coverage. About 36%, 36.5% of the people who did were people who don't get any financial assistance with their drug costs. And that's about 500,000 or so of these people. Collectively, for those 500,000 or so individuals, having that $3,300 cap resulted in a collective savings of close to $980 million. The office projected what they think is going to happen this year now that that $3,300 cap is only a $2,000 cap. They're predicting that by mid-year this year, more than 4.5 million people are going to have reached that catastrophic coverage level. What I also found super interesting from this research is they included a table that showed the top 10 drugs measured by out-of-pocket spending that are taken by the people in Medicare, or that were taken, by the people in Medicare last year who got to that cap. 9 of those 10 drugs are cancer drugs. The one outlier is a drug for treating cardiovascular disease. So I find it very meaningful to see that the cancer community is being significantly impacted in a positive way by these changes to the Part D benefit. The Inflation Reduction Act includes reforms that are beyond imposing that out-of-pocket maximum on drug spending. So our next question relates to a brand new program that the Inflation Reduction Act created called the Medicare Prescription Payment Plan. That's sort of a mouthful, so I'm going to call it the M3P when I'm talking about it. This is a program that lets someone spread the costs of their prescription drugs out over the year rather than having to pay a large amount of money all at once. This is a payment plan, not a savings plan. This is all about spreading out someone's costs. It's not about saving money. Whether someone enrolls or doesn't enroll, they are going to pay the same total amount for their drugs during the year. There are no interest payments, and the program is voluntary. So you can choose to enroll if you have a Part D plan or if you have a Medicare Advantage plan with drug coverage. The program is administered by the drug plans. Just like it's voluntary to enroll, you can choose to disenroll at any point, but if you do, you're going to have to pay whatever balance you owe. If you choose to enroll in this program, the way it's going to work is you go to the pharmacy to get your drugs, and you're not going to have to pay anything to the pharmacy. The pharmacy is going to let the plan know that you've gotten your drugs, and then the plan is going to send you a monthly bill for whatever amount you owe. and that bill is going to be separate from the bill the plan sends you for your monthly premiums. And then once you get the bill, you pay the bill the same way you would pay any other bill. I want to show you a couple of examples about how this works in practice, and the examples come from some resources that we are sharing on our website from a group called the MAP RX Coalition, the Medicare Access for Patients RX Coalition. Triage Cancer is a member, along with other patient and caregiver groups and health professional organizations that are committed to safeguarding the well-being of patients who have chronic diseases and disabilities who rely on Medicare Part D. So all of these resources are available on our website, and if you see the MapRx logo, you'll know where they came from. So let's start with Julie. Julie has an out-of-pocket cost of $600 at the pharmacy in January. She's prescribed a multiple drug regimen to treat her chronic condition. She expects to pay the same out-of-pocket cost per month for the rest of the calendar year until she reaches her $2,000 out-of-pocket limit. What is Julie going to pay on a monthly basis if she enrolls in the M3P in January? So before I break this down to the difference between not enrolling and enrolling, just focus on that last column called total paid. You see that whatever choice Julie makes, she's still going to pay $2,000. She's not saving any money by enrolling. She's just changing around when she owes the money. So if Julie doesn't enroll in the M3P, here's what happens for her year. Her drugs cost $600 a month. So in January, she goes to the pharmacy to get her drugs. She pays $600. She goes back in February and in March, and it's the same thing. By the end of March, Julie has already paid $1,800 in out-of-pocket costs for covered drugs. So in April, when she goes to the pharmacy, she only owes another $2,000 before she hits her out-of-pocket maximum. After April, for every month between May and December, she doesn't have to pay anything out of her own pocket. She just goes to the pharmacy and collects her medication. If Julie enrolls in the M3P, things look different. And this is the same data that was in the bottom row of the prior slide, okay? So the way it's going to work for Julie if she wants to enroll is she goes into the pharmacy in January. Her plan is going to look at whether her monthly drug cost in January, $600, is more or less than if the plan divides up her $2,000 out-of-pocket maximum evenly over the 12 months that remain in the year. $2,000 divided by 12 gets you to about $167. 167 is less than 600, and so all she has to pay for her meds in January is $167. Now, the full cost of those meds for her was $600. So the $433 difference doesn't go away, but it does get carried over to February. And in February, she owes another $600 to get her new prescription. And we add that to the $433 that was carried over for a total of $1,033. The plan divides that by the remaining months in the year at this point, which is 11 months. That gets you her payment for February of $94. And then the plan keeps doing this math for every remaining month in the year. It can get a little complicated. In a minute, I'm going to show you where you can get the math done for you. But just thinking of Julie right now, by enrolling in this plan, she can spread her drug costs out pretty evenly throughout the year, rather than having to come up with this really large amount of money for the first 3 months of the year. When someone enrolls in the M3P matters. So this is Julie again, but instead of getting a diagnosis and having to start on meds in January, she now gets her diagnosis mid-year and has to start in July. And there's a big difference. If she doesn't enroll in the plan, her year looks kind of similar, except starts out later. So she has to pay the full $600 in July, August, and September, By October, she's hitting her out-of-pocket maximum and only has $200 remaining to pay. And November and December, she's not going to have to pay anything to pick up her medications. She can still enroll in the M3P in July, but at that point in time, she only has 6 months remaining in the year to spread costs out over. So in July, when the plan is dividing that $2,000 out-of-pocket maximum, it's only dividing by 6, and it's getting her first monthly payment as $333, which is pretty much twice what she owed in January in the first scenario. You can see that she continues to owe less than $600 a month, but by the end of the year, her payments are still, they're pretty high. And there may be less value in her enrolling in this program. You can enroll in the M3P you could enroll last fall during open enrollment. You can enroll at any point this year, but when you do, influences how much of a benefit you're going to have. And so there's real value to people knowing about this program as early in the year as possible. Not everyone's going to benefit from it. Everybody's going to have to figure out for themselves if it makes sense. The people who are most likely to benefit are people who have high drug costs early in the calendar year. Some of the people who are not thought to be seeing a big benefit from this would be people who already get financial assistance with their drug costs. So that's people who are enrolled in full Medicaid, people who get extra help, people who have low drug costs to begin with, people who have relatively low drug costs or have relatively even costs throughout the year, and people who first start taking a drug at the end of the year. Medicare has a couple of places on its website that will help people figure out whether this payment plan will make sense for them. So the first place is a section of their website where they've gathered all the basic information about the plan. The link is on the slide, and this section includes what Medicare calls its plan wizard. The wizard will ask you a series of general questions about your prescription drug use, and based on the answers you give it, it'll tell you either, yes, we think this payment option is likely to help you, or no, we don't. The more helpful place where you can get exact information about your costs is in Medicare's Plan Finder. So I know a lot of you likely already know about Plan Finder. In case you don't, this is the part of Medicare's website where you can enter your zip code and see all the different Part D plans and all the different Medicare Advantage plans that are available to you based on where you live. You can enter details about the drugs you take and the dosages and quantities, and you can tell Medicare which pharmacies you use in order to get really detailed cost information. You can also log in using your online Medicare account, and if you do, some of that information will auto-populate and save you some time. Once you do all that, Plan Finder is going to give you a list of all the drug plans available based on your zip code. So in the case of the zip code I used here, there are 23 drug plans, and you can get the same list of Advantage plans in your area. Plan Finder is going to show you like a summary box, like what you see here for this plan, for every one of these plans. And then if you go to the blue rectangle at the bottom called Plan Details and click on it, you get even more detailed information about each plan. Once you're in the details for a plan, if you scroll to the section called Yearly Drug Costs by Pharmacy, you can see that below that table, there is this box with a blue rectangle, not a blue rectangle, I'm sorry, the box has like a blue bar across the top of it. This is where the Medicare Prescription Payment Plan calculator is located. You click on the link at the bottom of the box, and you're going to get a pop-up that gives you a table like the ones I showed you for Julie. It's just that Julie's were horizontal and this one is vertical. And it gives you a side-by-side comparison by month of what you're going to pay monthly if you enroll in the M3P or if you don't. You can also use this drop-down menu at the top And you can see if there's any variation based on where you're getting your drugs. So this one is what you're seeing on the screen is the mail order pricing, but you could flip to any of the different pharmacies that you've put into Plan Finder. If you want to enroll in the program, the only way to do that this year is through your drug plan. That's whether it's your Part D plan or whether it's your Medicare Advantage plan that gives drug coverage. You can't enroll at the pharmacy. You can't enroll by calling Medicare. The drug plan is in charge of administering the program. There's also no auto enrollment. So if you signed up this year and you want to sign up again next year, as of right now, you have to proactively do that. There is some conversation about switching that around, but so far it is just conversation. Nothing has happened to put it into place. If you had high drug costs last year, your drug plan was supposed to send you what they call a likely to benefit notice to tell you, hey, this new program exists and maybe you want to participate. This year, if you go to the pharmacy to pick up medication and you have a drug where the cost of that one drug is more than $600, the pharmacy is supposed to hand you a likely to benefit notice. What do you do if you get one of those? If you want to sign up, since you sign up at the pharmacy, what you can do is leave your meds there, go home, call your plan to enroll, and come back to the pharmacy the next day to pick up your meds. Plan enrollment is only supposed to take 24 hours to confirm. You also can enroll retroactively if a delay of more than 24 hours could seriously jeopardize your life or health. What happens if you miss a payment? If you miss a payment, your plan has to tell you and give you a 2-month grace period. And if you don't pay by the end of the grace period, the plan can remove you from the program. The plan can't cancel your drug coverage. The only way the plan can cancel drug coverage is if you don't pay your plan premiums. And then later on, if you pay off the balance you owe, or you can show there was a good reason you didn't pay, like you were hospitalized, your plan can put you back in the program. As is the case anytime a new program gets implemented, we expect there to be challenges around the M3P this year. First of all, we might see differences from one plan to another in how well it's working because the plans are in charge of executing this program, not Medicare. We think that there may continue to be challenges with people learning about the program. People are so skeptical of scams. Even when they get legitimate communication by mail, they might be questioning if what they're seeing is real. There is a general lack of knowledge, I think, about the program having been introduced in certain circles, which goes along with the fact that people have a general lack of knowledge sometimes about Medicare in general. The survey that you see on the screen or the study, it says that 7 out of 10 people who have Medicare don't compare their plan options during open enrollment in the fall. They don't read their notices or their annual notices of change. They don't do the research to find out whether the current plans they have are changing their terms or pricing for the following year. And if someone isn't doing their homework during open enrollment, there are things that are easy to miss, not just the creation of this new M3P program, but other things as well. And that brings us to our next question, which is, what if a drug that I need isn't covered by my plan anymore, and I only figure that out in the new plan year in January? This can be an issue if you switched into a new drug plan for 2025, and it can also be an issue if you stayed in the same plan you had and didn't realize the plan's formulary was changing. Every drug plan has its own formulary, its own list of drugs that are covered. Those formularies are broken down into different levels or tiers based on what the individual is paying for a drug and what the drug plan is paying for the drug. Lower tiers are where you have your least expensive generic drugs and your lowest copayments. Higher tiers, you start to find non-preferred drugs, brand name drugs, and eventually specialty tier and newly approved drugs. And those high tiers, or the highest tier, is unlikely to have a copayment. It's going to have a coinsurance so that the individual is on the hook for a percentage of total cost. Medicare has rules about what formularies have to cover, and for certain protected classes, including cancer drugs, plans do have to include most drugs, but they don't have to include all drugs. And if you fill a prescription for a drug that's not on your plan's formulary, you are responsible for 100% of the cost of that drug. And anything you're paying isn't going to help you satisfy your deductible or your out-of-pocket maximum. If you find yourself in a situation where you need a drug that's not on your plan's formulary, you have some options. One thing you can do is you can ask your drug plan for an exception. You can ask the drug plan to choose to cover the drug that wasn't on the formulary, or you can ask the plan to waive a coverage rule. So I'm going to go through the exception process in just a moment, but I want to talk about the coverage rules. Even though a drug that you need may be on your plan's formulary, the plan may have rules that restrict your access to that drug. They might require prior authorization. In other words, before the pharmacy can fill your prescription, it has to call and get special permission from the plan. Might have quantity limits. Drugs on the formulary, but only up to a certain amount, and you have to check and see whether the amount you need is under that limit. Or step therapy, where the plan says you're going to need to try an alternative drug or maybe a few alternative drugs that cost less money before we're going to let you step up and get the original drug that you were asking for. You can see all the information about what drugs are on your formulary and whether there are coverage restrictions by looking at the formulary itself. Usually you can navigate to that on your insurance company's website, but you can also see most of that information in Plan Finder. So if you are in the plan details section I mentioned earlier and you scroll to other drug information, you will see a chart that lists all the drugs that you entered. And then in the first column, it tells you what tier the drugs are on if they're covered. That is also where it will show you, in this case, about Revlimid, the third drug listed, that it's not covered on this plan's formulary. The other information you can get here is whether any of the drugs have coverage restrictions. So in this case, the two drugs that are on formulary don't have any prior authorization or step therapy requirements. If they did, you'd see the word yes in the appropriate box. But you do see that that first drug has quantity limits. And if this was live and I rolled my cursor over the word yes, I would see the actual quantity, like 30 pills per month. All of this information is in Plan Finder, whether you are looking at Part D plans or Medicare Advantage plans that include drug coverage. So let's talk a little about the exceptions. An exception is essentially asking the plan to make a coverage determination or make a decision and tell you that decision. There are two types of exceptions. The first are called tiering exceptions. This is when you are asking your plan to cover a drug that's on a higher tier of the formulary at the cost of a drug on a lower tier of the formulary. The second kind is a formulary exception. Formulary exceptions can be used in two different situations, either to ask that the drug not on your plan's formulary be covered as if it was, or to ask that the plan waive a coverage restriction, waive a quantity limit, or waive a step therapy requirement. You or your representative can ask for the exception, or the healthcare provider who prescribed the drug for you can ask for the exception. The key to having it granted is demonstrating that the drug you want is medically necessary for you. And to do that, you're going to have to get your healthcare provider who's prescribing the drug involved to help you submit what Medicare calls a supporting statement. Basically, the backup information that shows why the drug is medically necessary and also shows why any of the alternatives, like the drugs already on the formulary, are not as effective for you and or that the alternatives would cause adverse effects, like you're allergic to them or they cause harmful side effects. Once the drug plan has your supporting statement, it usually has to give you a written decision within 72 hours, but they have to give you the decision within 24 hours if you ask to expedite the request. And you can do that if you or your healthcare provider can show that if you had to wait the full 72 hours, it would jeopardize your life or your health or your ability to regain maximum function. If you ask for the exception and you get denied, you don't have to let things end there. You then have the right to appeal that decision. I'm not going to talk at length about appeals today. We do have a lot of information about them in our Cancer Finances module about Medicare, but you have the full right to go ahead and appeal that decision. Getting an exception is really important, not just so that you can access the meds that you need, but also to keep your costs low, because anything you're going to pay for a medication that's not covered by your plan isn't going to help you get close to that $2,000 out-of-pocket maximum. So all of the steps and the timing information that I just discussed are included and in additional detail in a brand new resource that we just put up on our website, and that is our checklist for how to make a Medicare prescription drug exception request. So I mentioned Revlimid earlier when I was showing you that example of a drug not being covered by a plan, and that was intentional. Revlimid is a really expensive brand name drug that is used to treat people with multiple myeloma. And I used it as an example because we are seeing that many Medicare Part D plans that included Revlimid on their formularies last year are no longer including it in 2025. Interestingly, we have seen the problem with all of the standalone Part D plans. We're not seeing that same problem with Medicare Advantage plans. So what do you do if you are someone who needs Revlimid and are only just realizing that it's not covered by your plan? And keep in mind, of course, these steps, I'm using them to illustrate a real life issue that we're seeing, but these steps could apply to somebody who is finding another drug is no longer covered by their plan. First, you want to confirm, just make sure, is your plan covering it or not? And if it's not, the next step would be to go and talk to your healthcare provider. So many plans that are no longer covering Revlimid right now are covering its generic version, which is called lenalidomide. Ask your doctor, is that an option for you? Could it work? At the same time, you can also request a transition fill. So during the first 90 days that someone is in a Medicare drug plan, Medicare allows that person to request a one-time 30-day temporary supply of a drug they were previously taking if that person just switched into a new drug plan, or if that person is still in their prior plan, but the plan's formulary changed and the drug is no longer on it. While you are requesting that transition fill, you can start the process of requesting an exception to see if the plan will cover the drug as if it was on formulary. And you're going to need your healthcare provider for that as well, because they're going to help you with that supporting statement to show why Revlimid is medically necessary. And in this case, you would need to show if lenalidomide is on formulary, why is that not a suitable alternative? Are you allergic to it? Have you tried it before and it has not proven effective for you? Has it caused a really bad side effect? In the case of lenalidomide specifically, there has been a shortage of it, so that could be mentioned. And then, of course, if your request is granted, your out-of-pocket costs for the drug are going to count towards getting you to that $2,000 out-of-pocket maximum. If your request is denied, you can move through begin to move through the appeals process. There's one more strategy for folks who are having that Revlimid problem, or for folks who are having any other issue in the new year. Maybe it's an issue with drug coverage. Maybe it is an issue with being able to see a provider that they had wanted to see. That leads me to this next question. Can I still make changes to my Medicare coverage now that open enrollment is over? So as a very, very quick review, for people with Medicare, think about it as a two-lane highway, and you're driving down one of the two lanes. You've either chosen original Medicare, where you have parts A and B, Part D for your drug coverage, and If you're in Original Medicare, you had the option or have the option to purchase a Medigap plan to help you with out-of-pocket costs from Parts A and B. The alternative to driving in lane 1 is driving in the Medicare Advantage lane, where you have one managed care plan that has bundled together hospital coverage, medical insurance. It probably includes drug coverage. The one thing you're not doing in lane 2 is purchasing a Medigap because you have an out-of-pocket maximum. For the most part, you've picked a lane for the year. You're not weaving in and out from one lane to the other whenever you want. But there are some times during the year where you can switch lanes. The major time that everyone has to do that is open enrollment, which just ended in December. But there are some enrollment periods that are still available. We are in the Medicare Advantage open enrollment period. This only happens between January 1 and March 31, and it is only for people who started out the year in an Advantage plan. If you started out the year in an Advantage plan, you can use this time period to switch to a different Advantage plan, or you can switch to Original Medicare and then enroll in a standalone Part D plan. And if you choose to do this, your new coverage is effective the first day of the following month. So if you are one of these people with a Revlimid issue, and if your issue, or pardon me, if you have started the year and you are currently in a Medicare Advantage plan, you may have another option and see to switch into a different Advantage plan. If you do that, you want to make sure that in addition to covering Revlimid, the new plan covers any of the other drugs you need. You want to make sure that your providers are going to be in network for the new plan. Or you can look into switching to Original Medicare and enrolling in a Part D plan. I would just caution you that, you'd have to find a Part D plan that would include Revlimid on its formulary. And the other caution with returning to Original Medicare is you're going to need to check your state's rules to see if you can purchase a Medigap plan if you make this kind of switch. We are also in the middle of Medicare's general enrollment period. This is an enrollment period that someone can take advantage of if they are someone who has to pay a premium for Part A and need to sign up, or if they want to enroll in Part B and they didn't do that during their initial enrollment period and they're not eligible for a special enrollment period. If you enroll in Part A with the premium or Part B during the GEP, as it's called, your coverage is going to start the first day of the next month. But be aware that you may have late enrollment penalties. You have some additional choices if you take advantage of the GEP. So if you use that and you're signing up for Part B, for example, and you then want to enroll in a Medicare Advantage plan, or you want to enroll in a Part D plan, you can take advantage of some other enrollment periods. And that's what this chart shows. The first of those is the initial coverage election period. This is for someone who has just become eligible for a Medicare Advantage plan. Remember, to be eligible to enroll in one of those, you need both Parts A and B. So if you only met that requirement during the general enrollment period, you now have a special enrollment period where you can pick up an Advantage plan. There's also a Part D special enrollment period for people who use the general enrollment period to enroll in Part B. There are lots and lots of special enrollment periods in Medicare. I'm definitely not able to go through all of them. I just really want to remind people that if you are having some challenges with your coverage, it may be worth looking and seeing if there is a special enrollment period that is available to you. And then I want to mention one new special enrollment period for this year. This is actually, it's a new special enrollment period, but it replaces a previous special enrollment period for the same groups of people. This is for people who get financial assistance with their Medicare costs. So this is for people who have both Medicare and Medicaid, or they have Medicare and a Medicare savings program, or they have Medicare and extra help. Beginning January 1st, if you or a patient is in one of these categories, you can make a change to your coverage as frequently as once a month. When you make a change, it's effective the first day of the next month. but there are some limitations on the kind of changes someone can make. So they can switch, if they're in a Medicare Advantage plan, they can switch back to original Medicare and then get a Part D plan. Or if they're in original Medicare and they have a Part D plan, they can change to a different Part D plan. What they can't do is they can't go from original Medicare to Medicare Advantage, and they can't change from one Advantage plan to another, although there are some very limited, very specific exceptions to that. So while we're on the topic of people getting financial assistance, the next couple of questions relate to that topic. One of those is, what happens if I'm starting out in the new year and I learn that I've lost my status in the Extra Help program? Extra Help is a federal program that helps people pay for the costs of their Medicare prescription drug coverage. The program is run by Social Security. Its official name is the Low Income Subsidy. If you are eligible for Extra Help, you get a Part D plan, or you can get a Part D plan that has no premium and no deductible. And in 2025, you're going to pay no more than $4.90 for generic drugs and no more than $12.15 for brand name drugs that are covered. There are income and resource limits to be eligible for this program. Your income has to be under 150% of the federal poverty level. The new federal poverty level numbers just came out about 2 weeks ago. So for a single person to be able to get Extra Help, their income has to be under $23,475. And for a couple, it would have to be under $31,725. On top of that, your resources have to be under the numbers that are listed on the slide this year. Enrollment in Extra Help goes through Social Security, not through CMS, the Centers for Medicare and Medicaid Services, the agency that runs Medicare. You're going to Social Security for this. Some people get Extra Help automatically. If you have full Medicaid, if you have a Medicare savings program, or if you get SSI, you automatically get put into Extra Help. But the income and the resource limits for Extra Help are higher than the limits for most of the other need-based programs. So there are people out there who aren't going to qualify for Medicaid or an MSP or SSI, but are going to be able to qualify for Extra Help. And for those people, what they have to do to enroll is they have to proactively apply by calling Social Security or going online. The reason I'm highlighting Extra Help right now is because of some circumstances that are unique to last year. So post-COVID and post the public health emergency, a lot of people lost their eligibility for Medicaid and for Medicare savings programs. This past fall, approximately 1.4 million people in Medicare got a notice. It's a gray notice, it's on gray paper, telling them that they were losing Extra Help. And the reason that most of these people got the notice is because they had lost Medicaid, but they'd lost Medicaid a while ago. There's a lag time between losing the Medicaid and getting this notice. So these are for people who lost their Medicaid between July of 2023 and the end of June 2024. And even though they had lost their Medicaid, they got to keep Extra Help through December 31st of last year. But as of January 1st, they no longer have it. Just because these are people who lost their automatic eligibility because they had had Medicaid doesn't mean that they're not actually eligible for Extra Help. So if you are in this situation or you're working with people in this situation, when they got their letters, the letters had applications accompanied in the envelope. They can fill out the application and return it. They can also just go onto Social Security's website or call Social Security and see whether, based on their current income and resources, they are still below the levels where they can be eligible for help. Extra Help is, just one of the programs that's out there to help with Medicare costs. So in the new year, are there other options to help pay for other out-of-pocket costs from Medicare? First option someone has is to see if they are eligible for full Medicaid. There are close to 13 million people in the US who get both Medicare and Medicaid. Medicaid eligibility rules differ state to state. And we did just get those new federal poverty level numbers. So you have to check with your state to see how the adjustments to those numbers have impacted eligibility for Medicaid where you live. There are, of course, a lot of people who are not going to be eligible for full Medicaid, but who are still struggling. And another option for them are Medicare savings programs. There are 4 of these programs, each with its own name and acronym. For short, we call them QIMBY, SLIMBY, QI, and QDWI. Each of these programs pays for certain premiums, either for Part B premiums and or for the Part A premium just for the people who have that premium. But in addition, the QIMBY program, which is the most generous, also pays for someone's Medicare deductibles and coinsurance and copayments. Eligibility for these programs is also based on the new federal poverty level numbers. So the table on the left shows the income limits as they've been revised for this year. These are the federal limits. So states have the option, if they want, to be more generous than what the federal government sets, but they can't be less generous. Connecticut, DC, Indiana, Maine, Massachusetts, and New York have more generous income thresholds than what the federal government provides. And then Illinois and Mississippi use the federal limits, but they disregard certain types of income to make it a little bit easier to qualify. On the right side of the slide, you see resource limits to be eligible for the 3 main Medicare savings programs. Those are the same state to state, except that the states in the middle bullet have decided we're not looking at resources. If you're in one of those states, you just have to meet your state's income test in order to be eligible. And then the 3 states at the bottom have higher resource limits than what the federal government sets. If you think you're eligible for an MSP or you're working with someone you think is eligible, how do they enroll? They do that through their state Medicaid office. But there is data that says fewer than half of the people who are eligible for these programs actually enroll in them. So at the end of 2023, CMS issued a rule to try and do something about that. They basically issued a rule where they are directing Social Security to talk more to state Medicaid agencies to try and get more people enrolled. And in particular, the rule addressed 2 different situations. One is when Social Security knows someone is in SSI, and they address the idea of getting people who are on SSI into the QIMBY program as long as those people are eligible to have premium-free Part A. These rules got very, very detailed, but I would say on a general level, the way it works is if someone has SSI, they're automatically eligible for Medicaid. And then for that population, they should be eligible for the QIMBY program as well. But then the way it gets handled will be different state to state, depending on if that person is able to get premium-free Part A. The other thing that this rule did is it told Social Security, hey, for the past 10 years or so, the law has required you to share information you have about people who get extra help so that you, the state Medicaid agency, will start MSP applications for these people. Even though it's been the law, many states don't do it. So this rule told these states that they have until the beginning of 2026 to comply. We have already covered a lot of things, a lot of information. And is that all there is? And the answer to that is no. I actually just tried to get in the highlights, the things that I thought would be most useful for all of you to hear, but there are a number of other topics that are new or on the horizon. I'm going to share just a little bit about 3 topics that you may be hearing about. The first is another Medicare reform that came from the Inflation Reduction Act, and that is drug price negotiations. The IRA allows the federal government for the first time to negotiate drug pricing directly with drug companies to try and expand access to drugs and lower prices. So far, negotiations have only covered drugs under Part D, but starting in 2028, Part B drugs like chemo administered at a doctor's office are supposed to be covered as well. Last year, the government finished negotiations for the first 10 drugs that had been selected for the program. They're on the slide. The negotiated prices for those drugs are supposed to become effective in 2026. There are very lengthy and complicated guidelines about how they came to choose the drugs that they did. Among other things, these are drugs with no generic alternatives. They're drugs that are at least 7 years past their FDA approval. They aren't orphan drugs, meaning they're not approved just to treat one rare disease. And then there was a whole set of rules around pricing and trying to figure out which drugs should have their prices negotiated. It is not just about choosing the 10 most expensive retail drugs that are covered by Medicare. It really had more to do with how much money overall Medicare is spending on the drugs. So some of the drugs you see may be less expensive than drugs you are very familiar with from a retail perspective, but it could be that the drugs you're seeing are taken just by so many people on Medicare that the overall spending was much higher for them. On January 17th, 15 new drugs were selected for price negotiation this year, and the prices are supposed to be effective once they are decided on in 2027. This list has a number of cancer drugs on it, but I want to call your attention to the first set of drugs listed, Ozempic, Rybelsus, and Wegovy, because that leads us to another sort of hot topic in the news, and that is about anti-obesity meds. Medicare by law is not allowed to cover certain types of drugs or drugs for certain uses. And one of those excluded categories are drugs that are used to treat anorexia, weight loss, and weight gain. Some of these drugs, though, can be covered if they are being used not to treat obesity, but to treat other conditions like type 2 diabetes or cardiovascular disease. At the end of last year, CMS issued a proposed rule to reinterpret the old law that says Medicare can't cover these drugs for weight loss so that they can, in fact, be covered for treating obesity. The comment period for that rule ended just a few days ago, so we're going to have to wait and see what happens. A lot of factors got us to this point. Obesity is obviously a major health issue, not just in and of itself, but it's also a major risk factor for a lot of other chronic diseases. These meds are being prescribed more and more frequently. Most commercial insurance is covering them. But because of just how many people take these medications and how many millions of people would meet the criteria for being obese, if Medicare chooses to cover the drugs, it could cost the program a really, really significant amount of money. So we need to stay tuned and see what happens with this. And then the final thing that's new for 2025 has to do with hospital status. Status refers to whether someone is an inpatient or an outpatient at the hospital. Inpatients are people who've been formally admitted with a doctor's order, and someone's last day as a hospital inpatient is the day before the day they get discharged. Inpatients are obviously not the only people getting care at a hospital. You might be in the hospital emergency room. Maybe you're at the hospital having outpatient surgery. You can be spending the night or even several nights in a hospital and still not be an inpatient. You might be under observation status, where the doctor is still figuring out whether or not they're going to admit you. Why do we care about this? First reason we care is it impacts cost and the part of Medicare that covers the visit. So if you are spending a night in the hospital under observation status and you only have Medicare Part A, you're going to have a problem because Medicare Part A pays for inpatient hospital stays, not observation stays when someone's an outpatient. The other reason this matters is because if after your stay at the hospital, you need to recover at a skilled nursing facility, in order for that skilled nursing facility stay to be covered, among other requirements, you need to have what's called a qualifying hospital stay that precedes it. To be qualifying, the patient has to have spent 3 days as a hospital inpatient. Sometimes you hear this as 3 midnights. Because the day that you're being discharged isn't an inpatient day. And this can end up being tricky because sometimes someone has spent 3 nights at the hospital, but they weren't all nights where they had been admitted. In October, CMS issued a final rule that created a new appeals process only for certain people with original Medicare if they are initially admitted to a hospital as an inpatient and then reclassified by the hospital as an outpatient under observation status. So I'm going to say this again. This is only for people with original Medicare. It doesn't apply to people with Advantage plans. And it's only for people who initially got classified as inpatients and then got reclassified as being under observation status. If you got to the hospital and you were immediately told that you're under observation status, you don't have a right to appeal that decision. For the people who have this new appeals right, the process is going to look a lot like the process that we already have to appeal a hospital discharge. The new process is supposed to start on February 14th. These changes, this new rule came about because of a class action lawsuit that has been kicking around for a long time now, actually, to go through all the different courts and to get through CMS and to get these new rules. And because of that, the new rule created what we're calling a retrospective appeal right as well. And that means that if between 2009 and when this new process starts, if you have original Medicare and you were admitted to the hospital initially as an inpatient and then reclassified as being under observation status, you can appeal that retrospectively. But if you want to do that, you have to do it by January 2nd of next year. Okay, finally, we are up to our last question, which may have been the very first question you had. And it's definitely the question that my colleagues and myself are being asked the most. We had an election in November, and we have a new president, and we have new congressional leadership, and we have new federal agency officials, and we have some federal agency officials who have yet to be designated. What does that mean for everything that I just talked about? So I have an answer to this, although it may not be a super satisfying answer. The truth is, no one knows exactly what's going to happen right now, right? Nobody here, unfortunately, has a crystal ball to reassure us. What we can tell you is everything that we have talked about, that I have talked about so far today, is currently the law. And until we find otherwise, it continues to be the law. The new administration may come in and change certain laws as we know them. And certainly at any time, people file court challenges and legislators do, work to change things that have existed in a certain way for a certain amount of time. Our goal here at Triage Cancer is to keep you informed about changes in the laws as we find out about them. So check our website. Subscribe to our blog, subscribe to our newsletter, get updates. We are going to share information when we get it. And everything we've shared today, as I said, is the current law. We can also share some of the things that we're already hearing from the new administration. I can tell you that at the very beginning of the year, a bill was introduced in Congress to repeal the Inflation Reduction Act. Nothing's happened with that bill yet. Even if something happens with it, we don't know if that means it's going to get repealed, if it means everything in the law will be repealed, or only parts of it. But yes, this could influence or impact the out-of-pocket cap on drug costs, or the M3P program, or drug negotiations, or other reforms that law brought about that we didn't even talk about today, like capping the cost of insulin. There has certainly been lots of talk about controlling healthcare costs and controlling Medicare costs specifically. In the past, one suggestion that people have floated is raising the age of Medicare eligibility from 65 to 67. There has been discussion about shifting more people into Medicare Advantage plans and reducing provider choice. There has been discussion about increasing the use of utilization management techniques, things like prior authorization, which aren't used nearly as much in Medicare, or pardon me, in original Medicare as they are in Advantage plans. There has certainly been a lot of talk already this year about cuts to Medicaid. Cuts to Medicaid impact the Medicare population, not just all the millions of people who rely on having Medicaid also to help them pay their healthcare costs, but others. Medicaid is the only government insurance that pays for long-term care or for certain home and community-based services. So these are all important issues to follow. We can tell you with certainty if you care about these things, if you don't want to see changes to these programs or to other programs, you have to make your voices heard. You have to contact your elected officials so that they know that their constituents want to protect these programs. There's already a lot of chatter that President Trump's executive order freezing federal funding was rescinded due to a huge public outcry. So speaking up matters. We have an advocacy topics page on our website. One of the things that you can find there is a link to where you can get names and contact information for your elected officials. You can also see charts that we have that show you relevant legislation that's being discussed either by Congress or in state legislatures about Medicare, but also about other cancer-related legal issues. And you can see links to different advocacy coalitions that we are a part of and the actions that those coalitions are taking, and get involved, for example, and get on mailing lists where you can get copies of letters that you can send to your elected officials to try and make engaging in advocacy a little easier. You can definitely subscribe to our blog. That's where we will share advocacy opportunities. And I encourage you to attend our February webinar where the topic is all about advocacy opportunities and getting engaged. I'm going to turn things back over to Shelby in just a minute, but I will just remind you that if you have more Medicare questions, we have a Medicare topics page where you will find the links to all of our Medicare-related resources. And other places besides Triage Cancer where you can go with your questions include calling Medicare directly. If you have a drug plan or an Advantage plan, you can call that plan directly. And then my favorite resource to recommend, which is your State Health Insurance Assistance Program or SHIP program. Those programs have volunteers who provide free counseling to people with Medicare and to caregivers. Many of them have counselors that either will talk to you over the phone or meet with you in person. And with that, Shelby, I think all the questions I'll confirm were answered.
Yes.
Okay, great. So I'm flipping it back to you.
Thank you so much, Amanda, and thank you, Monica, for answering all of the questions in the Q&A box. We invite you to attend the rest of our webinar series. We have a few topics on the screen, but you can visit our website to see the full schedule and register, triagecancer.org/webinars. We also post recordings of all of our past webinars on our past webinars page. We have our flagship event, Triage Cancer Conference. This event is open to anyone. We have one coming up on May 17th and another in the fall. And we're going to cover topics like advocacy, health insurance, and finances. And for the healthcare professionals on the call, we do have a full online training for you. We are going to cover topics like Medicare and Medicaid and navigating disability insurance. These are some of our 2025 dates. We have both in-person and online dates available. You can see the full schedule and register at triagecancer.org/intensive. And if you are a community health worker, or you know a community health worker, we have a training on June 25th. This will be virtual, and you can sign up on our website for this. And I just want to note that for all of our live events, we do provide continuing education for healthcare professionals. Again, I wanted to remind you about our legal and financial navigation program, where we will explain your options, provide accurate information, and empower you to take the next step. Please fill out the intake form at triagecancer.org/gethelp. We invite you to stay connected to Triage Cancer by attending the rest of our webinars, keeping up to date with our blog by scanning the QR code on the screen now. You can connect with us on social media. Our handle is @triagecancer. And if you are a healthcare professional or simply looking to help out your community, you can actually order materials and we will send them to you in bulk and for free if you fill out this form on the screen. And we want to hear from you, so please scan the QR code on the screen to share your experience or visit triagecancer.org/testimonials. We are always looking for ways to improve our program. And for the healthcare professionals who want to receive continuing education credit, you must have attended the entire webinar and you must complete the evaluation and post-test that will be sent to you via email 24 hours from now. You must receive a passing grade if you are a nurse or a social worker. And if your screen looks something like this, then you are all good to go, and that means you passed. But if your screen looks something like this, then unfortunately you did not pass, but a link will be available for you to retake the post-test. And you have one opportunity to retake the test. For those of you who do pass, all certificates will be sent to you within 4 weeks. Thank you so much for being here today, and we look forward to seeing you at our next event.